40th live webinar on orthopedic principles. This time we have Dr. Rajiv Limai once again with us. He works as a consultant orthopedic surgeon and foot and ankle surgeon at Northeast Hospital, United Kingdom. He's also associated with the University of Teesside in Middlesbrough, UK, and he's also part of the MCH program at the University of Teesside. Dr. Limai is going to enlighten us on tendinopathies around the foot and ankle. Over to you, Dr. Limai.
Thank you very much, Hitesh. Thank you. Afternoon all. I hope you are all well. So this time we are going to talk about the tendinopathy around the ankle and foot. Now, this condition is not only becoming very common, it's very common in your clinical practice, as well as this comes into the exam scenario. The FRCS Orth exam will have some of the common tendinopathy patients as well. So it's worthwhile knowing from both perspectives. So starting with the tendinopathy, we need to know about the physiology of the muscle and tendon. So as we are all aware that the muscle and tendon works remarkably well with the stress. So any excessive stress on it leads to thickening of the muscle fibers, thickening of the tendon, it increases the activity, and it leads to increased function. However, repetitive stress leads to reduction in the function of the tendon. It leads to reduction of the density of the tendon, and it leads to atrophy of both tendon and muscle. So what's the exact pathology in this problem? The pathology is the impaired blood supply that leads to loss of normal collagen, deformity of the tendon, deformity of the joint. So why is there pain? The pain is due to neovascularization or neural growth. The pain is due to stretching of the mechanoreceptors, and it also leads to release of some nociceptive neurotransmitters such as substance P. So how do you assess these patients? The patients come in with symptoms of pain, swelling, and reduced muscle function. They may also have reduced joint activity. They will have swelling in the tendon, and there's obviously lack of activity. So initially the diagnosis is clinical, but it's augmented by ultrasound and the MRI scan. Now the MRI scan is usually done to find out some other pathologies in the joint. So although the ultrasound will provide you most of the diagnosis, the MRI scan is an augment. So how can we manage them? We can manage them non-operatively initially, of course, and then go on to surgery. So what are the goals of management? They must be to either reduce or remove the cause of damage, improve healing response, and prevent further damage. So there are various options to try out. Go through some of them very carefully now. They're very effective. However, the general rule of thumb is if somebody is not responding to non-operative management, revert to surgery, or at least consider surgery and have a chat with the patient. So in the foot and ankle area, there are many tendons that can be affected. The commonest being tendoachilles, posterior tibial tendon, tibialis anterior tendon, peronei, and other tendons. So the pharmacological strategies include anti-inflammatory medication. How do they work? They work by reducing the toxic inflammatory chemicals or the chemicals which will cause the pain. There's also a possibility of steroid injection locally. However, we talk about complications such as tendon rupture, especially if the cortisone injection is given inside the tendon. Physical therapy or physiotherapy still takes the main part in the treatment. The initial treatment is RICE, which is rest, immobilization, compression, and elevation, followed by training modification, splintage, taping, and eccentric exercises. The anti-inflammatory medication can go alongside with it. However, there is very lack of randomized studies to compare the results of conservative versus surgical therapy. Hence, the cutoff limit of 6 months is somewhat arbitrary. The eccentric exercises, which are described by which suggest 3 sets of 15 repetitions twice a day, 7 days a week for 12 weeks in total is essential. It leads to upregulation of insulin-like growth factors. It leads to improvement of the cellular proliferation and matrix remodeling. The next stage would be extracorporeal shockwave therapy. There are many, many studies that are coming out with the outcomes of these. However, the results are not very consistent. They are divergent results. It depends on multiple factors such as the type of the shockwave therapy, intensity, frequency, and all the rest of it. The effect is with the help of endorphins. It does increase the metabolic rate and increases blood supply, and thus removes the pain source and improves the function. However, we found that the results can be inconsistent or divergent, as I mentioned earlier on, and the therapy is expensive. The next stage would be high volume injections. Now, these are done along with the help of ultrasound. Suggested that sclerosing agents could be beneficial as it leads to reduction of neovasculogenesis, and the use of something called polidocanol, which is a vascular sclerosing agent, will give a better outcome. However, there are no long-term studies available. The use of aprotinin is somewhat getting popular these days. It acts as a MMP inhibitor, or it neutralizes the metalloproteinase enzyme, which is supposed to be cause of the degeneration of the tendon. There's been a couple of studies which are described the outcomes in about 400 patients in study by Orchard, which says 76% improvement up to 54 months. But there's been a recent RCT published by Brown, which says 26 patients divided in two groups, one with saline, one with aprotinin, has found no significant difference at 52 weeks. So it makes you think again. Roll-up PRP is getting more popular. We are using PRP for almost everything. We're using it for tendons, muscles, joints, and it is supposed to be one of the therapy that is taking a lot of randomized controlled studies. It does provide cellular and humoral mediators. It leads to cell proliferation and increase in type 1 and 2 collagen. However, there are a couple of important studies to note. One by Dragu, which is on patella tendinopathy, which says good outcome. However, I was part of one of the local multicenter trial of which the results are awaited at the moment. We have completed 250 patients and the results are awaited. What are the roles of hyaluronic injections? It does give possible biological effect and helps to reduce this, the anti-inflammatory effect. It leads to cell proliferation and it also leads to lubrication. Some of these combinations will have mannitol in it, which reduces the swelling. There's a couple of studies described recently by Petrella or Moneta. However, these are non-ankle studies. I've been doing this study ourselves, and the long-term efficacy has not been published yet, but we have got 24 patient study for up to 6 months only. Stem cells are emerging studies. They are undifferentiated cells, which leads to healing of the tendon. It can be isolated from various tissues. And there's a big study by Obed, which is a 40-patient randomized control trial, which says one with placebo effect and one with stem cell at 6 months showed significant improvement only using the visual analog score. However, the visual analog score is not really the ultimate diagnostic thing. Hence, we need to do more SF36 or maybe is seen in sports patients as well as non-sports patients. There's a 30% risk of any sort of tendinopathy in runners. However, we have seen with active population lately, we can see this condition in any age now. Repetitive loads lead to fatigue failure, and hence it leads to micro tears and leads to degenerative thickening of the tendon with improper healing. This is a theory proposed by Kujula in 2007, which is very popular. So involvement in the foot and ankle, like I mentioned earlier on, we have two common tendons, which we will discuss in this talk and which come in the exams as well, are the posterior tibial tendon and Achilles tendon. Some other tendons are also involved, such as peroneal, tibialis anterior, and smaller tendons of the extensor tendons. As we know that the posterior tibial tendon is the longest in the posterior compartment of the calf, it becomes quite a long muscle, belly and tendon, and it is initially quite deep, but becomes superficial later, just around the ankle joint, goes posterior to the medial malleolus, and inserts in all tarsal bones except talus. The anatomical reasons for its dysfunction are certainly like hypovascularity, sharp angular turn, and the involvement of synovium at an early stage. However, any of these causes can lead to repetitive stretching of the tendon, and stretching by almost a centimeter can lead to dysfunction of the tendon with thickening, micro tears, and tendinopathy. So as we know, the pathophysiology starts with synovitis and hypovascularity. It leads to tendinosis. It leads to micro tears and stretching of the tendon. Further on, it leads to macroscopic tears, and then it leads to loss of the arch of the foot, leading to flat foot deformity. In the later stages, it goes on to develop subtalar or even ankle joint osteoarthritis. So in stage 1, you will see pain and tendinitis, but normal working tendon. There's a little bit of swelling around the medial side of the ankle. In stage 2, one starts to get the deformity of the tendon, leading to inflammation and elongation. It leads to flexible flat foot formation, and pain increases, more localized both on the medial side as well as goes on to the sinus tarsi region. It leads to instability, restricted walking, and pain in the hindfoot. In stage 3, pain starts to disappear from the medial side because the pathology is more or less constant on this side, but then it goes on to the lateral side. There is impingement between the fibula and the calcaneum, and the peroneal tendons get impinged. There's fixed deformity, and there's more flattening of the foot with midfoot break as well. And in stage 4, there is more rigid fixed flat foot deformity and associated with pantalar arthritis. Like I mentioned in my previous talk, in the exam scenario for the FRCS, you will get patients from stage 2, stage 3, and sometimes stage 4. So please prepare this topic very well. Now, the management goes with the stages of the disease. An associated condition needs to be addressed, and sometimes multidisciplinary approach should be taken, such as rheumatologist, anesthetist, pain specialist, etc. In stage 1 management, it's mostly non-operative. So we can provide arch supports, ultrasound, immobilization in cast if required, or a cast boot, non-steroidal anti-inflammatory medications, or surgery for decompression of the tendon with tenosynovectomy only in stage 1. In stage 2, it becomes mainly surgical. It leads to either repair of the tendon if the tendon repair is enough, or decompression of the tendon, FDL tendon transfer, or flexor digitorum longus tendon transfer with medial sliding calcaneal osteotomy, sometimes associated with lateral column lengthening or Evans osteotomy, and also cuneiform osteotomy depending on the level of the deformity. There are some occasional reports in the literature about split tibialis anterior tendon transfer. However, the results are not good and hence must not be performed unless there is a strong reason to. So the usual treatment is calcaneal medial shifting osteotomy, as it's depicted in this picture. And the fixation is done using one screw. And then associated with flexor digitorum longus tendon transfer with augmentation using something called internal brace, which is depicted in this picture to reconstruct the spring ligament construct. In stage 3, the end stage flat foot deformity with hindfoot arthritis, surgery is done as a salvage procedure with some form of arthrodesis, so be either subtalar joint arthritis leading to subtalar joint fusion, or triple arthrodesis, or even in stage 4, when it becomes very disabling, pantalar fusion or hindfoot fusion, including tibiotalo-calcaneal fusion, using either a long nail or a plate. It does lead to correction of the deformity. However, it leads to a very stiff hindfoot. Moving on to the next one, which is important again from the exam perspective, is the Achilles tendinopathy. And it can be divided into insertional variety or mid-portion variety. The classification was given by Cook, and this is very important classification to remember to find out the exact location of the problem and the treatment associated with it. So it's the longest and largest tendon in the body. It forms the origin from gastrocnemius and soleus, and it has an insertion on the calcaneal tuberosity. As we're aware, it lacks the synovial sheath, but has a paratenon. The insertional tendinopathy is the commonest variety that we see in our practice here in the UK. It can be seen in mid-portion Achilles tendinopathy as well, but the results of this particular condition is somewhat slightly better than the mid-portion Achilles tendinopathy. So it is approximately 50%, and there are various surgical options provided. Techniques revolve mainly around 5 procedures, and there are 3 main studies which have shown the benefit of the incision or the posteromedial incision or resection of bony prominence and reattachment of the tendon by using suture anchors. There are 2 other studies which have described all above, but augmentation routinely using the flexor hallucis longus tendon transfer. So if it's a straightforward, simple, mild deformity, one has to follow this typical parallel pitch sign as depicted here. And then the area of the bone that is above that line is resected and an anchor is used, or sometimes a repair of the Achilles tendon is done by this technique, by also given from Arthrex recently, and this is also quite popular. If, however, 50% or more of the tendoachilles is degenerate, then primary FHL transfer is essential, and that is done by harvesting the tendon in the back of the tendoachilles, passing some sutures around the tendon, and then inserting that tendon through a drill hole into the calcaneum fixed with a biotenodesis screw. There are some arthroscopic techniques nowadays described, which are called endoscopic calcaneoplasty. There is a published literature from Van Dyck in Netherlands and Nicola Mafuli in London. It does have a higher learning curve, and it leads to some incomplete resection being a problem, again, in the form of resection recurrence. Our experience in my unit, we have treated approximately 16 in 15 and 16, 2015 and 2016, we have treated 42 patients, and we saw reduction of the visual analog score from 9.5 to 3, leading to a significant benefit for these patients. We did have 4 recurrences, and where the repeat surgery was necessary. However, we do approximately see about 30 to 40 patients each year. Now, some of them are treated open, some of them are treated arthroscopically, but it depends on many conditions, such as professional or semi-professional football, or any other sports players, or patients who are recreational sportsmen. We discuss the technique with the patient and take their views into account, whether they want to do it open or arthroscopically. We routinely take their scoring pre-op and post-op. We routinely audit their procedures, and then we have increased our activity offering arthroscopic techniques now. Moving on to the second variety that is seen also in the exam scenario is the non-insertional Achilles tendinopathy, which, as the name suggests, is above the insertional zone of the Achilles tendon, is further up. This is where the insertional or Haglund's deformity comes. This is where the non-insertional comes. The diagnosis is again with the history and clinical examination. And the clinical tests include palpation test, tendon loading test, and squeeze test. Imaging is commonly done to confirm the diagnosis and to see if there are any other problems. As you can see, it is a very common problem in the European population. It is becoming common in rest of the world as well. And it has about 60%, 50 to 60% of total spectrum of tendoachilles disorders. The combination of various causes such as training, errors, drugs, steroids, combination of inflammation and degeneration causes the problem. So who needs the operation? The operation is needed in 50% of patients only. There is risk of open surgery, and that leads to recurrence of the condition in approximately 11% of patients. And although open surgery has quite a significant success, sometimes you have to do an FHL tendon augmentation. So the surgical treatment are divided into 2 or 3 different techniques. One is the tendoscopy, which is a latest technology, followed by the MIS procedures, where the stripping of the paratenon and anterior fat pad is done using either minimally invasive procedures or by an arthroscopy, and open techniques such as stripping and augmentation of the tendon using FHL. Coming on to the tendoscopy first, it has a promising initial results. However, the learning curve is high, and it leads to more complications if one is not used to it. The arthroscopic technique that we use has to have a good triangulation technique. And with the insertion from either lateral or medial side, the neurovascular structures are at risk. The resection of the plantaris tendon is considered to be one of the important features in the treatment of non-insertional tendinopathy. There's a couple of important studies published in 2014, which shows 32 elite athletes at the mean age of 23 months with the excision of or resection of plantaris tendon showed 90% success rate. In our unit, we're still identifying the use of this procedure and the role of the procedure. So hence, I'm not offering this to each and every patient. So hence, we rely more on the open techniques. And the open techniques can be done by a patient in the prone position, posterior longitudinal incision, slightly posteromedial, hence the sural nerve is protected. The pre-Achilles tendon the area is exposed by opening the fascia, paratenon is exposed, and then the stripping of the tendon is done from the anterior side. Sometimes a small area of the tendon itself is excised as to decompress the tendon and debulk the tendon. And then after the debridement is done, we assess how much tendon is remaining. If there's good 50% or more tendon remaining, we can simply stitch the tendon back or suture the tendon back. But if there is a significant loss of the tendon, then you may have to consider FHL tendon transfer. As you can see in this, a strip of the tendon is being excised. So in our experience with open techniques, we find better outcomes. And we've done a particular year again, we picked out 25 patients, and we saw that the visual analog score dropping from 9 till 2, and the AOFS scoring, the American Foot and Ankle Surgeon score going from 26, which is quite painful, to 90, which is significantly beneficial. A certain number of patients will still be benefited by an osteotomy tendon injection in addition to our injection therapy, or even after the surgical exploration. A brief word on the Achilles tendon rupture. It is very common, as you know. There are various studies described as to which treatment is better, whether it's surgical, whether it's non-operative or conservative. There's a UK trial which is confirmed recently, which is called UK STAR trial. And this has shown that the outcomes following the repair, as well as surgical repair and the conservative management, the outcomes are pretty much the same. However, 1 year down the line, the push-off strength was seen to be less in patients with conservative therapy. Hence, in my practice, I always would personalize these cases and then treat them accordingly. So keep an option of surgical treatment still open. You can do it with either mini incision or big incision like this. Percutaneously you could do, or you could do an open repair, or maybe augment it with the FHL tendon or any other tendon required. The mini open techniques have found better role, and there are various studies published in this article which has shown that minimally invasive repairs of the Achilles tendon repair work much better. So the mini open can be done like these, or there are some instrumentations from various implant companies like these to provide that access to mini open techniques. The neglected ruptures of the Achilles tendon is becoming a common problem, especially in elderly population. The assessment, although is tricky, it reduces the strength of the tendon, leads to recurrent falls, and patients are not happy following the management. The treatment for these patients will generally be an isolation of the flexor hallucis longus tendon and tendon transfer into the calcaneum using a biotenodesis screw. So we've reviewed these neglected ruptures in our review article in 2018, and we have come up with various positive findings, as the preoperative MRI scan to identify the gap is very essential. And we have had excellent outcomes in patients we have treated in 2018, followed by a regular follow-up for these patients and FHL transfer in neglected cases. So in conclusion, tendinopathy is a very common entity in sports as well as non-sports population. The surgical management only is indicated when conservative measures fail for at least 6 months. And although conservative measures are important, please consider surgery if they are not working. The outcome should be aimed at the needs of the patient. So it is very important that we individualize each and every condition for each and every patient, and the outcomes are given accordingly. Thank you very much for your attention.
Thank you, Dr. Limai, for that brilliant presentation once again.
Thank you.
There are a couple of questions. One is like, in patients with Haglund deformity,
Yes.
what are your complication rates of surgery? Is it very high? So do you really wait for quite a long time until you really suggest surgery?
No, like I mentioned earlier on, 6 months is generally required for non-operative management. So you could try that with various things. However, the lump is not going to disappear. So the lump is always going to be there. And sometimes it's essential that if the patient has problems because of the lump, then you go in for surgery at an early stage. If the patient has problem because of tendinopathy, then you could try the conservative measures. So sometimes patients come to me with a large lump in the back of the heel. They can't get their shoes in. They've got constant rubbing on their footwear, and in which case you may have to go early. Especially in the Haglund's lump, one could go in early. So you don't have to wait for 6 months if the patient is very badly symptomatic.
So you prefer arthroscopy assisted or open surgery for the Haglunds?
No, I personally would go for an open surgery. And the results are mixed with arthroscopic technique. Like I mentioned earlier on, one would end up with either damaging the tendon or maybe resecting a little less than what you would normally. And hence the lump remains at the back of the heel again. Eventually, what happens, the back of the heel where the lump is removed, you will get some bone formation again and some fibrosis. And not infrequently, these patients end up with some stiffness and some recurrence of the bony deformity again. And especially if you go in with open surgery, you can reduce that bony lump to minimum, or you can shave it down to minimum visually, and then it is much safer. And there are much, much better techniques of reattaching the tendons now, such as the anchor
And
sutures. Yeah.
how about your wound healing problems? Do you encounter a lot of wound healing issues with Haglund's excision?
So that's a good point to note, because the posteromedial incision is probably the best in case of incision to the back of the heel, because you can maintain the vascularity in the scar. I have seen some patients come to me from elsewhere where the incision was taken right on the tendon and the incision was deepened through the tendon, like a paratendinous incision, through the tendon, in order to open the Haglund's lump, thereby reducing that vascularity. Because if you look at the actual area where the highest numbers of complications are, it is either on the lateral side or directly on the tendon. And if that skin wound fails to heal, the tendon is exposed, and then we are in big trouble. Posteromedially, however,
Very, very important point.
it's a very important point, because I've seen one or two patients having that sort of complication come to us from elsewhere and unfortunately ended up with plastic surgeons, because there's hardly any skin. So all they need then is some form of flap. And that is the worst outcome you can expect. So in my experience,
Exactly.
yeah. So posteromedial.
Exactly. Even I have seen a very similar scenario where people have resected the Haglunds using a direct posterior incision, wound healing issues, non-healing, and ended up with a flap.
Indeed. So posteromedial
Point is
incision.
very important.
Yes. The posteromedial incision is safe. It's very, very fine.
Okay, so that is a very, I think one of the most important take-home messages of this lecture is that if you're going for a Haglund surgery, take a posteromedial incision.
Indeed. Absolutely correct.
And what do you think is the response to conservative as well as surgical treatment for non-insertional tendinitis? Non-insertional.
Yeah. So non-insertional tendinopathy, initially we'll start with the non-operative management, like we mentioned again. And there are various techniques now, and most of these techniques work well up to 6 months. There are some patients who will come back to you with some pain, and these are the ones which you can't really dodge then. You can't just keep telling them to go home and do non-operative management. You've got to come to a point where you may have to change that decision. So in my hands, if they don't work for 6 months non-operatively, then I would offer them either surgical treatment in the form of open decompression and removal of that little bit of central part of the tendon and repair, or use tendoscopy, where you would put an arthroscopy from lateral or medial side and use a shaver from the opposite side and shave the anterior side of the tendon. The anterior side is where the neovasculogenesis is, and the pain is coming from the front of that tendon rather than from back of the tendon. So if you shave that area, either that is by open or arthroscopic technique, it works really well. And I think that is what I would definitely suggest.
So would you do a preoperative, you'll do an ultrasound and an MRI to delineate your resection, right?
Correct. And that's why the MRI would give you the best sort of delineation about how much pathology is on the anterior side How much of neovasculogenesis can be seen by color Doppler or by ultrasound, and then you know where to attack. So it's mostly the anterior side of the tendon. It's never the
And
posterior side.
and how much, suppose you resect, say, like 50% of the tendon, like you have found on your preoperative MR, there is a significant lesion in MR, and you are going to resect, say, 50% of the anterior aspect of the tendon of a
Yeah.
particular. So how much resection do you think is a cutoff, and you think of an augmentation with a FHL?
Yeah, that's a very important question, because many surgeons I've seen happily doing up to 50% debridement. What happens at that point is, even if you repair the tendon, the natural strength of the tendon is reduced significantly. And these are the patients who come back with a rupture of the tendon at a later point. Now that rupture then becomes like a complete rupture. So although once we have gone in to excise that central part of the tendon by a longitudinal incision, the rupture then becomes a transverse sometimes. And then you end up requiring to go back in again to repair that Achilles tendon. So going back to repair the tendon, you will see that there's very little tissue to repair back. And hence, it is very important that if you're taking 50% of the tendon out initially, it is very easy to harvest the FHL just underneath. And you dissect the FHL tendon all the way down to the posteromedial side of the ankle. And all you need is about 3 centimeter long tendon to be able to insert into the calcaneum through that drill hole and put a biotenodesis screw. And if you look at that combined construct of the repair of the Achilles and the FHL transfer, the repair is very, very strong. And then you don't have to worry about how much strength the Achilles is going to be. And even if they rupture, they've got a fantastic tendon transfer working.
And did you mention about plantaris resection for this? Or what did you mean? Under what circumstance would you mention about plantaris resection?
Yes. So there's a recent theory which is very similar to the analogy is given like shoulder problems, if you like. In the long head of biceps could be a cause of pain in shoulder pathology sometimes. And when many shoulder surgeons go in to do a shoulder arthroscopy, let's say for rotator cuff, they resect the long head of biceps. So similar sort of theory has been described by Nick Van Dyke in Netherlands. And his concept is that if somebody has got thickened tendoachilles, which is non-insertional, they may also have pain coming from plantaris tendon. And these are the plantaris tendons which you can resect either by doing arthroscopic technique, because it's more or less easy to see it through arthroscopy, and then resect it open while you're doing the excision of that central portion of the thickened tendon. Again, whether it's the right cause of the problem, we don't know. It is just one of the theories. And like I mentioned in my slides earlier on, again, it's not a definite whether or not resection leads to the improvement. It's just thought to be one of the causes. So if you're there, you might as well do it. That is the theory. I personally, however, I must admit, I don't do it routinely.
Okay, because that is going to change clinical practice a lot, because if plantaris tendon has a significant role, that's going to, I mean, it's going to help a lot.
Absolutely.
And since we are talking a lot of injections, do you prefer PRP in any of these?
Yes, like I mentioned, we are doing PRP for many things now. We're doing it for joint arthritis. We're doing for shoulder indications, foot and ankle indications. And one of the indications that we have recently completed a study on is the non-insertional tendinopathy of the Achilles tendon. So what we have done recently is we have completed a multi-center trial with 250 patients recruited into it. And we have done the specific PRP injections. Now, the difference between the PRP injection and the hyaluronic injection is that the PRP is injected inside the tendon. It's not peritendinous, it's in the tendon body. So you're actually inserting the needle into the tendon body, and the results are supposed to be better. Now, having said that, our study is just only completed, so I can't really give you an outcome on that just as yet. But maybe in the next 6 months, once we have re-examined all the patients, we'll know if that was the benefit. On the other hand, the hyaluronic injection is in the peritendinous region. It's not inside the tendon. And that is the fundamental difference.
And you also mentioned about aprotenin, right?
Yes.
So do you have experience in using aprotenin for any of these?
So I don't personally, but some of our physiotherapists do. And some of our musculoskeletal physiotherapists who are trained in doing injection techniques have used it. Personally, I don't have any experience with it. However, I put that for completion.
Okay, is it more expensive to hyaluronic acid or something?
It is expensive, indeed. It is expensive, and it has more local reactions. And to be honest, there are not many studies out there which has given the benefit of aprotein over, let's say, steroid or PRP or stem cells or hyaluronic acid. Hence, everything is possible. But again, whether it will work in the longer run, we don't know. So it's something that is a bit of a minefield there.
The other question is, we all know that steroids can lead to a tendon rupture if you're giving it to the tendon. But what about steroids if you give it into the sheath under ultrasound guidance?
That's absolutely fine. Tendon sheath injections with ultrasound control is very safe, very effective. Many patients get excellent benefit of that. Question is how long that will work for, how many injections can you give, and if something is not in the right space, then whether it will be more deleterious rather than beneficial. And that is something one has to be aware of. If the tendon is affected directly by steroids, then it will rupture, as we know.
Okay, Dr. Lima, I think there are no more questions, and we had a very fantastic session once again, and thank you.
Thank you so much.
And every time we come online, we have a lot of stuff to learn from you, and I'm sure all our readers are going to really enjoy your lectures.
Oh, thank you so much for your invitation.
Yeah, the lecture will be archived in another 3 hours, and it'll be available for free to watch anywhere across the world.
Thank you very much again.
Thank you, Dr. Lima, once again.
Thank you.
Yeah, bye-bye.